Welcome to Senior Playbook. Today I want to dig into a nutrition problem that quietly affects a huge number of older adults: vitamin B12 deficiency. Depending on which research you look at, somewhere between 3 and 40% of older adults have some degree of deficiency. That matters because B12 is essential. It's major in red blood cell production, so low levels lead to anemia. It supports nerve function throughout the body, which means a deficiency can contribute to problems with thinking, memory, and walking. And perhaps most frustrating of all, this condition is frequently overlooked in primary care. That makes it worth understanding so you can advocate for yourself or a loved one. What is vitamin B12? Also called cobalamin, it's a water-soluble vitamin critical for DNA synthesis and cell division. Your bone marrow constantly produces new red blood cells, and B12 is essential to that process. It also plays vital roles in nerve function, both in the brain and the peripheral nerves throughout the body. Many of these functions work alongside folate, vitamin 9, but folate deficiency is much less common because many U.S. foods are fortified with it. You get B12 from most animal products, not plant foods. If you eat meat, eggs, or dairy, you're generally getting enough. Vegans need to supplement intentionally. The recommended daily intake is just 2.4 micrograms, but your body stores a reserve in the liver, enough to sustain you for about a year before symptoms appear if you stop absorbing it. A typical Western diet provides 5 to 7 micrograms daily, more than enough. After you take B12 in, it has to be processed by stomach acids and enzymes, then absorbed in the small intestine. Intrinsic factor, a protein secreted by cells lining the stomach, binds to B12 so it can be efficiently absorbed. Without intrinsic factor, the body can still passively absorb a tiny amount, roughly 1%, but that's not enough under normal conditions. Why does deficiency become common with aging? As people get older, they develop conditions that reduce absorption. Lower stomach acid, often from a weakening stomach lining, atrophic gastritis, or acid-reducing medications for heartburn and GERD. Metformin, widely used for decades to treat diabetes, interferes with B12 absorption, even though it's not a stomach medication. If you're on metformin, don't be alarmed. It has an excellent safety record and may even counteract some biological aging effects. But awareness of the B12 issue matters. Heavy alcohol use irritates the stomach lining and interferes with absorption. Surgeries that remove parts of the stomach or intestine and conditions like Crohn's or celiac disease can also reduce absorption. What are the symptoms? Since B12 is especially vital for red blood cells and nerves, symptoms relate to those two systems. First is anemia, a low red blood cell count. B12 deficiency anemia features cells that are larger than usual, unlike iron deficiency anemia, where cells are smaller. Anemia causes fatigue and shortness of breath. Second is neuropathy, peripheral nerves not functioning properly. This causes tingling, numbness, burning sensations, poor balance, and walking difficulties, often from a combination of impaired sensation and reduced muscle control. Third is cognitive impairment, problems with memory, thinking speed, or executive function. It can show up as irritability, impatience, or subtle personality changes because the brain nerves managing memory and thinking are affected when B12 is insufficient. One more sign worth mentioning: when B12 is low, certain metabolic compounds build up in the body, notably homocysteine and methylmalonic acid. You may have heard the term pernicious anemia. That's an older term for a specific form of B12 deficiency caused by the body losing its ability to make intrinsic factor. An autoimmune process damages or destroys the stomach cells that produce it. Without intrinsic factor, you can't absorb enough dietary B12. It affects about 2% of older adults. Importantly, symptoms related to nerves or cognition can appear before an obvious drop in red blood cell counts. Why does B12 deficiency get missed so often? The main reason is that the symptoms, especially in older adults, are non-specific. Fatigue, anemia, neuropathy, cognitive decline, walking difficulties, all are frequent in older adults and often multifactorial. These are sometimes dismissed in primary care as just part of aging, which is a form of ageism that unfortunately still occurs. Another factor, B12 deficiency develops slowly and insidiously. It creeps up gradually, so people may not notice the changes. And when B12 levels come back low normal, those results ideally prompt a confirmatory test, but that doesn't always happen unless providers pay close attention or patients advocate for themselves. Who should be tested? Routine screening of everyone isn't currently recommended, but certain groups definitely should be. Any older adult experiencing symptoms, fatigue, anemia, neuropathy, memory or thinking problems, or walking difficulties should be checked. When I evaluate someone with cognitive concerns, checking B12 is always on my list. Test anyone with risk factors, metformin, acid-reducing medications, GI issues, heavy drinking, or a vegetarian or vegan diet. How do we test? It's simple. Start with a blood test measuring serum B12. A normal level is usually 300 picograms per milliliter or higher. If deficiency could be causing anemia, folate typically checked too. A complete blood count catches anemia. But remember, you can have clinically low B12 without anemia yet. I've seen families told testing wasn't necessary because there was no anemia. That's not correct. Symptoms can develop before anemia does. If serum B12 comes back under 200, deficiency is confirmed. If the level is borderline, 200 to 400 picograms, the next step is a confirmatory test, usually methylmalonic acid. This compound accumulates when the body doesn't have enough B12 to process it. Elevated methylmalonic acid indicates a clinically significant deficiency. How do we treat it? Treatment is simple. Supplemental B12. It works very well. Prescription or over-the-counter formulations, typically 1,000 micrograms as either an intramuscular injection or a daily oral tablet. It's very safe. You cannot overdose on B12. Excess is simply excreted in your urine. Which is better, the shot or the oral? For a long time, injections were the standard, but research shows high-dose oral B12, 1,000 to 2,000 micrograms daily, is just as effective as injections for treating deficiency. Remarkably, this even works for pernicious anemia, because that inefficient passive absorption still functions, and when the dose is high enough, absorbing just 1% provides more than the body needs. One caveat with oral, the person must take it consistently every day for months to replenish stores.
If this video helped you, do us a quick favor and hit that like button. It helps more seniors discover these tips. Drop a comment below and let us know which tip surprised you the most. We read every single one. And if you haven't already, subscribe to Senior Playbook and tap the bell icon so you never miss a new video. Your next chapter starts here. We'll see you in the next one.